Okay, go for it. All right. Thanks everybody
Yeah.
for coming. Tonight, Liz will present on diabetic ketoacidosis and acromegaly. And we're away. I'll hand over to Liz. Thanks, everyone.
Okay. Hi, everybody. Thank you for coming to these clinical pearls for DK and acromegaly. And Anna probably quite aptly labelled DK diabetes ugly friend. And although acromegaly is not particularly ugly, it probably does fit in the posse with diabetes. So we'll be covering both of those tonight, although most of it will certainly be on DKA. So what I did want to talk about is DK is mostly divided between dogs and cats quite evenly, but then I will just be talking solely about feline acromegaly. We won't be covering any canine growth hormone disorders. So sorry if you're really excited about that, but they're just pretty rare. So we'll kick off with DKA, so diabetic ketoacidosis. And there has been a couple of good summaries on diabetic ketoacidosis in the literature, one specifically about cats in JFMS. And then if you are particularly interested in the fluid and electrolyte disorders that accompany DK in more detail than what I will be covering tonight, then there is another recent review of that as well in the Vet Clinics of North America article. Now, I was actually really excited to talk about DK as I think it's one of those diseases that can be really quite intimidating. And since the theme of this endocrine sort of continuing education series is about trying to be really clinically relevant, I was actually quite excited to share my thoughts on this quite complex disease in the hope I could make it just a little bit less scary. But as I was then sort of writing the talk, I realized that to really manage this disease, there are some aspects of pathophysiology that are really quite important to understand. So I understand if this picture summarizes your mindset right now when I talk about pathophysiology, but I've tried to keep the pathophys simple and have only really gone into aspects which are really super important for management. So what you do need to remember from the basics is that glucose is what really drives the production of energy, and that's in the form of ATP by the mitochondria within the cells. And even though there is this increase in blood glucose levels in this disease, the body's cells are just starved of energy. Insulin is really needed for the glucose to get into cells where it's used to make ATP or is converted and stored as glycogen in the liver and muscles, or triglycerides and adipocytes. So without insulin, that glucose can't move intracellularly, and then it can't be used for energy and stored. So as an alternative energy source, most cells use free fatty acids. So lipolysis, so the breakdown of fat, generates and liberates these free fatty acids into the blood. And hepatocytes can then uptake these free fatty acids and convert them either primarily to triglycerides, but also to a lesser extent to ketones. And so free fatty acids can then decide whether they want to enter the citric acid cycle, or they can be converted to acetoacetate and beta hydroxybutyrate. So in the case of just a bog standard uncomplicated diabetic, the body is going to convert most of the excess free fatty acids down to triglycerides with a citric acid cycle. And ketone production is low enough that it can be managed appropriately by the body. It's the opposite in DKA, where the citric acid cycle here just becomes completely overwhelmed, and ketogenesis here is what really prevails. And then as ketone concentrations increase, they can't be efficiently metabolized, and then you're going to see hyperketonemia. Adding on top of that is the body's response to illness. So the body increases its production of glucoregulatory hormones, so that's insulin, glucagon, adrenaline, cortisol, and growth hormone. But because of the lack of insulin in this disease, either through an absolute lack of insulin or a relative insulin resistance, the glucogenic effects of the stress hormones are just completely unopposed by the liver and muscle and adipose tissue. And that leads to this excessive ketone formation and fat and muscle breakdown, and you get this catabolic state. So essentially these stress hormones are going to promote ketogenesis. And what distinguishes DKA from that uncomplicated bog standard diabetic is that you get not just the absolute or relative lack of insulin, but it's going to happen in combination with an increase in your counter-regulatory hormones, so your glucagon, cortisol, adrenaline, and growth hormone. So in a study of cats with diabetic ketoacidosis, they noticed that cats will develop ketosis over about 10 to 30 days once they have marked insulin deficiency. Now, it does not necessarily require concurrent disease, although in DKA cases we do often go looking for that. But they found that after 16 days of experimentally induced hyperglycemia, which in this study they defined as a glucose of 30 millimoles per litre, that beta-hydroxybutyrate ketonemia was present. So that's after 16 days. However, ketonemia did not occur if blood glucose was less than 17. So if you're sort of getting early diabetics that have very sort of low glucose levels, the risk of ketonemia in those cases is going to be unlikely. So as you all know, a diagnosis of DK really involves documenting hyperglycemia, glucoseuria, either ketonemia or ketonuria, and a metabolic acidosis. And one of the main ways that we would be doing that is by using the urine dipsticks. So most urine dipstick reagent strips use this colorimetric method that measures the nitroprusside reaction, and that's for detecting specifically acetoacetate in either blood or urine samples. Heparinized plasma samples can be used on urine ketone strips, and we know that blood measurements are much more precise than urine measurements. Ketones will be evident in blood samples before they're going to be present in urine. So that's why it's often a preferred test. And excretion of ketones really relies on having some normal renal perfusion and function. And that may not be present in a dehydrated DKA patient. So testing blood is definitely preferable to urine. The key thing with urine dipsticks is that most brands of urine reagent strips measure only acetoacetate and acetone. And this is a problem as the majority of ketone bodies in our DKA patients actually made up of beta-hydroxybutyrate. The dipstick reagent strips do not measure beta-hydroxybutyrate, which is important because that's going to be detectable often before there are detectable levels of acetoacetic acid. So just remember what you're testing for when you use these urine dipstick strips and what you might not be testing for. So monitoring of a beta-hydroxybutyrate is going to be preferred. In addition, remember that beta-hydroxybutyrate is going to be formed from acetoacetate in the presence of hydrogen ions. So the more acidotic the animal, the more beta-hydroxybutyrate is going to form. If you wanted something more specific, there are certainly some handheld ketone testing strips, so a bit like glucometers, but for ketones, and they will measure beta-hydroxybutyrate. So that is something that you could look into if you do have a decent population of diabetics in your clinic that you're worried about DKA. So what I did really want is for these talks to be clinically relevant, as I said. However, with DKA, we really do need to talk a little bit about the pathophysiology. So just bear with me now, as this will become relevant when we talk about how we address hydration and fluid rates a little bit later in the talk. So what you need to remember with hyperglycemia is that it just has this major effect on fluid volume and on electrolytes absolutely throughout the body. So in diabetes, when there is this absolute or relative insulin deficiency, glucose will remain either in your intravascular space or it's going to diffuse into your interstitial space. So glucose cannot enter the cells as the cell membrane isn't really permeable to glucose. And as a result, because the glucose is in the intravascular space or in the interstitial space, glucose is going to draw fluid from your intracellular space and it's going to move into the vascular and interstitial spaces. So as this fluid moves across this way, you're going to get an intracellular dehydration. So this intracellular space is going to become dehydrated. What we then see in DKA is that you get this really profound osmotic diuresis. So it can be really, really significant. So when glucose, and I apologize, I tried to keep these these pictures as basic as possible. So they are very basic, so just keep that in mind. So with this osmotic diuresis, what we see is when glucose exceeds your renal threshold, it's excreted and passes through the renal tubules. And glucose is really good at holding water. So as the glucose goes through these tubules, it holds the water there and prevents water from being reabsorbed, so going back this way. And this results in water being lost in urine, and that's why we see a polyuria. Now, because of the lack of this water reabsorption in the kidney, there is going to be a decrease in your vascular volume, and fluid is then going to shift from your interstitium into the vascular space. So fluid is going to move this way. And so what we then see is an interstitial dehydration that follows. And the issue with DKA is that ketones significantly worsen this whole process, so this osmotic diuresis. So once you get an intracellular dehydration and then you get an interstitial dehydration, there is just no fluid left to move into the vascular space. So you then get an intravascular dehydration or a hypovolemia. So that's how dehydration takes place, and that's really important when we look at how to correct this dehydration when these patients present to us. So what we do see is with DKA is that you do have to have an acid-base disorder with DKA. So DKA is characterized by having a metabolic acidosis with an increase in your anion gap. However, the important thing to keep in mind is that if your DKA patient has a history of vomiting or of diarrhea, then the severity of that DKA acidosis may actually not be that clear, because you might get a metabolic alkalosis that can be seen with vomiting and diarrhea. Acetone, it gets formed through the spontaneous decarboxylation of acetylacetoacetate, that actually doesn't contribute to your acidosis because acetone doesn't dissociate, but that is actually slowly excreted by the lungs. And that's what generates this sweet smelling breath in DKA that some people can recognize. Now, the severity of hyperosmolality can be really variable in DKA, so I don't want to spend too much time on it, but you certainly can calculate the osmolality if you're super keen to do it. So the hypertonicity in DKA is going to be due to an increase in concentration of solutes that do not cross across cell membranes. So think about sodium and glucose. So with hyperosmolality, that's defined as a serum osmolality greater than 330 to 350 in cats and greater than 325 to 330 in dogs. So again, when we think about our different fluid compartments, as the osmolality or the tonicity of your extracellular fluid increases, water shifts from your intracellular compartment to your extracellular compartment. So again, that's where we're seeing that cellular dehydration that we were talking about. And the nervous system is the principal organ that's going to be affected by this shift. And that's why cellular dehydration can manifest as neurological abnormalities. So you'll see disorientation, ataxia, lethargy, seizures, and certainly coma in the really severely affected ones. What the body does do is it has these protective mechanisms called idiogenic osmoles, and they're created against this glucose-induced hypertonicity, and they're really important consideration for treatment and management of DKA, but I don't want to go into them too much tonight because that's a whole nother conversation. So essentially, when you're treating DKA, the goals of your DKA treatment are going to be restoring your intravascular volume and resolving your hydration. You need to address the electrolyte abnormalities and address your acid-base abnormalities. You need to decrease your blood glucose concentration, eliminate ketones, and identify and treat contributing disease. The treatment of DKA is relatively straightforward, but what is really tricky about DKA treatment is that there are just so many variables, and it's about fine-tuning the principles I just mentioned for each patient. But really the take-home message for vets is you want to use a crystalloid fluid, you need to use insulin, and you really need to frequently check your blood glucose, electrolytes, and pH. And if you do this, then you really do have a really good chance of being successful in resolving all of the abnormalities that you're seeing. So if we go looking at the treatment and we want to look at the type of intravenous fluid therapy, DKA patients have an interstitial dehydration and that intracellular dehydration. So giving a crystalloid fluid is what's needed. So 75% of that fluid is going to naturally shift from your intravascular space into your interstitial and intracellular spaces. This occurs really quickly, and that's really important to remember. So your choices for fluid type are normally either something like 0.9% saline. That one's a good fluid type because it provides the least degree of a transcellular osmolar shift in severe hypoglycemia cases. It's often chosen as most patients are hyponatremic. However, don't forget that a component of hyponatremia can be a spurious finding when there's hypertriglyceridemia. However, it's an acidic fluid, and that may not correct acidemia as effectively as a more balanced isotonic solution. Also, to keep in mind, it may cause a temporary hyperchloremic metabolic acidosis, and that's due to the increased chloride content and the lack of buffer. And that's really not ideal, as DK patients already have a high anion gap metabolic acidosis. So then I sort of think of my other category of fluid types as things like Plasmolite, Normasol, and Hartmann's. And they're really going to be adequately sodium supplemented and adequately buffered to help you resolve the metabolic acidosis. I think that probably where some of the confusion with DKA comes is that some of the older literature really supported 0.9% saline, and there has definitely been a transition to other fluid types, but it's a bit confusing if you're reading multiple different resources and they're listing different fluid types as their preference. So I guess stick with what you're most familiar with, but equally just keep in mind the limitations, particularly with 0.9% saline. So if we then look at your fluid rates, and they're really important, and they're actually one of the, I think, most time-consuming components of managing a DKA because they really need to be constantly reviewed. So your very first step when deciding on what fluid rate to use is you need to estimate your dehydration. So I've listed in this table what you would expect to see at particular levels of dehydration. And just as a side note, it's written so that only the new findings that occur at the level of dehydration are listed. So all the previous findings would also be expected to be present. So based on, clinical signs of skin tenting or sunken eyes or tachycardia, you can then decide what your percentage of dehydration is likely going to be. Having said that, you do need to account for individual variability with other diseases and also with species. So dogs can often tolerate a really large volume fluid resuscitation. Cats, they just don't tolerate it, and you'll really easily fluid overload a cat with DKA, even if they don't have a murmur or any history of any cardiac disease. So in the cat, I'll often take it much more slowly, and I'm going to watch them so much more closely when I'm fluid resuscitating them. I don't commonly personally reach for a colloid, so like hydroxyl ethyl starch, as you really want to restore appropriate volume in the intracellular and that interstitial space. You don't want to just hold volume in your intravascular space. However, I would consider hydroxyl ethyl starch in a cat before I would probably consider it in a dog, but it's not something that I reach for very commonly. Interesting, in humans with DKA, they actually just assume that they all are 5 to 10% dehydrated. And the guidelines in human hospitals is that 50% of the deficit should be replaced in 8 to 12 hours, and then with all the other dehydration corrected within about 24 to 36 hours. So we've estimated our percentage of dehydration, and we're going to correct a percentage of that probably in our first 6 hours or so, likely using a balanced crystalloid, so Hartmann's or Plasmolite, something like that. However, if they have heart disease, I'm going to take my fluid resuscitation much more slowly. But on the flip side, if they're severely dehydrated without heart disease, I might be doing my fluid resuscitation a little bit faster, or at least sections of it a little bit faster. So it really does depend on the patient. We will talk a little bit later about when we start insulin, but I personally don't start insulin straight away. Your intravenous fluids are going to change your electrolyte abnormalities, so referencing your potassium, phosphate, and sodium. So your fluids are already doing something about all of those parameters. So whilst I will pay attention to these parameters on presentation, it's really just to rule in or rule out if they're dangerously high or dangerously low, and in which case I'm going to pay more attention to them. However, in that first few hours, I'm really more focused on restoring fluid volume, and I know that my fluids are going to change those electrolytes pretty quickly. So I'm in my first 6 hours of these cases, and I'm going to reevaluate the electrolytes to see what my initial fluid resuscitation efforts have done, and then I'm going to start to address them a little bit more specifically. Once I've done that, so I correct the remaining dehydration, I'm addressing my electrolyte abnormalities and the acid base, that's going to take me about 24 hours. So make sure you give yourself a realistic time frame in which to achieve these things. After that first 24 hours, I'm going to then reassess the fluid rate. I've probably started some kind of insulin in that time, which we'll talk about, and I've started some of my electrolyte supplementation. So all of that probably happened in the first 6 to 12 hours of hospitalization. But if they're still dehydrated 24 hours in, I really need to reassess my calculated dehydration deficit. So looking back at that table. However, hopefully I've got it right. And if I have got it right, then the patient is now hydrated, and I'm going to then start to calculate my ongoing requirements. So accounting for ongoing maintenance and ongoing losses. If they're really severely polyuric, a urinary catheter may be a good idea at that point to match ins and outs. So as you're correcting your hydration, you need to be constantly checking the patient. So the physical exam findings that you use to initially determine your level of dehydration, all of those parameters should be improving. As much as there's human guidelines, DK is a disease where you can't really just use a blanket fluid volume for every patient. And they have actually done subsequent studies in humans looking at standard levels of dehydration, where every patient received the same amount of fluid, so without a physical exam or a personalized recommendation. And they actually documented overzealous volumes of fluid administration in up to 2 out of 3 patients. So they actually overachieved on their fluid resuscitation. So it's really important that we constantly look at our patients. One of the aspects that I think is often overlooked is I just love using body weight trends. So they're really easy to do. It's obviously much easier if you've had the patient. So for example, for me, if the patient has presented to me from the very beginning of its DK treatment, because we're using the same set of scales and so on to watch for the trend. But if you've sent a DK patient over to me, then I'll absolutely be going through all of your records to pull out every body weight measurement that I can. It's a really useful tool, and it costs you nothing. So if you diagnose your patient, let's say, with being 10% dehydrated, so you're seeing sunken eyes, you're seeing depressed mentation, then 10% dehydration should correspond to approximately a 10% body weight gain if you've rehydrated them appropriately. So your 10-kilo dog is going to become an 11-kilo dog after fluid therapy. So that's a really easy way to tell if you're on track or not. So I will often weigh patients every 4 to 6 hours. I really like every 4 hours, as it means I get a really good trend. And then if you get this sort of random outlier with one weight, you can just ignore it because you're still getting all your other numbers either side of that are looking pretty good. The other thing to watch for is you really need to be knowing the volume that the patient is urinating, even if it's only subjectively. So go outside and watch these dogs urinate, or look at what the cats are producing in the litter tray, because if they're properly hydrated, they should be urinating a lot and doing it frequently. So remember that these patients are polyuric from all of that osmotic diuresis. So when they are rehydrated, they should really, really be urinating. So again, I chart for my patients to go outside every 3 or 4 hours, or they have their litter tray checked frequently, because if they're not urinating every time they go out or every time they are checked, then alarm bells for me are starting to ring that they're still actually quite dehydrated. And if you measure their USG, really it shouldn't be greater than about 1.015. We'll briefly just touch on cerebral edema so you have that on your radar. So sudden changes in osmolality lead to these fluid shifts from the extracellular into the intracellular compartment in the CNS. So current recommendations is that if you're worried about that, you should be using an initially quite slow rehydration rate. So aim to rehydrate in 6 to 12 hours. Don't do it super quickly within just a couple of hours, and potentially using a low insulin dose. And this is going to gradually decrease the osmolality. It's really important in cases that present if neurologic signs are present on presentation. So you might need to be a little bit more conservative with how you rehydrate them. So rehydrate over 24 to 48 hours and using a slightly lower insulin dose. It doesn't mean that your rehydration is slow for that whole 24 to 48 hours. It probably will come sort of waxing and waning. So if you're really worried it's life-threatening, you might initially do it a little bit more aggressively and then back off a little bit more. So it's not a blanket rate for that 24 to 48 hours. So potassium is a really important thing to look at. So almost all dogs and cats with DK are going to be hypokalemic. So whole body potassium depletion is really, really common, even if their serum potassium concentration is within the normal range, or even they can actually be increased in some of these patients on presentation. But as you treat them with fluid therapy, you're going to get an increase in your GFR, you're going to get this increase in urinary excretion of potassium, and also you're going to start to alleviate your metabolic acidosis. And that's really going to lead to potassium shifting from your circulation into your intracellular space. So you really need to be anticipating that your potassium is going to drop during hospitalization. So if, for example, your serum potassium concentration is within the normal range, so that 3.5 to 5.5 millimole per litre mark, particularly in your early period of treatment, then the majority of time you'll actually probably want to put some potassium supplementation in, so 20 millimoles per litre of potassium chloride into your fluids at that point. If it's low, you obviously want to supplement more aggressively, and there are various tables like this one here in various textbooks just to help guide you. But it's really important you avoid administering more than half a milliequivalent per kilo per hour. If you do, it's normally only in severely hypokalemic cases, so when it's less than 2 milliequivalents per litre, but it's best to try and avoid that if you can. And in a lot of these tables, it will tell you the maximal fluid infusion rate that you can give for a particular concentration of potassium chloride. Really important thing is that you just make sure you mix any potassium supplemented fluids really well before connecting the patients. And I think DK is probably the one where I'm most paranoid about a patient getting a potassium bolus, because it's not uncommon to be having 80 millimoles of potassium chloride in a litre bag. So really important you mix that really well. The other consideration with hypokalemia is that your insulin therapy is going to move potassium into cells. So if my potassium level is really low, that's another reason for me to just initially hold on insulin therapy until my potassium concentration is a little bit more appropriate. The other parameter to have on your radar is phosphate. So during treatment, phosphate is driven into cells, and that causes an intravascular hypophosphatemia. And the main clinical signs that that's developing is going to be muscle weakness and a hemolytic anemia. So phosphate can be supplemented in IV fluids, normally in the form of potassium phosphate. So for example, a protocol that we'll often use is to supplement sort of a third to 1/2 of your potassium supplementation can be added as a potassium phosphate solution, and the rest as a potassium chloride solution. Really important to remember that potassium phosphate is incompatible with like a Hartmann's, so it needs to be in a calcium-free crystalloid fluid. So you need to put that into 0.9% saline. Serum phosphate should really be monitored every 6 to 12 hours after starting insulin therapy. The frequency really does depend a little bit on the rate at which it's dropping or potentially increasing. But the number to have on your radar is that a serum phosphate concentration that's less than 0.5 millimoles per litre is probably going to be associated with that intravascular hemolysis. So certainly anything lower than that, it probably needs to be supplemented, or if it's heading in that direction, you probably need to look at supplementing that. So insulin is actually quite a big topic in this disease. So we want to give insulin as continuously as we can. It's the only drug which is going to stop that ketone development. And what I think people find confusing is when blood glucose levels get lower and lower and they're approaching the normal range, that the instinct is to stop the insulin treatment. But that's actually not what you want to do. You actually want to keep giving the insulin, even if that means supplementing your fluids with IV glucose to achieve that. The exception to that is obviously if they're hypoglycemic from your insulin, then by all means stop it. But keeping that insulin going as long as it's safe to do so is really important. And the goal is to reduce your blood glucose by no more than 3 to 4 millimoles per litre per hour until you get into about less than 14 millimoles. So you don't want to drop your glucose too rapidly. So some of the controversy with DKA comes from when to start insulin. So the debate is really focused around whether we should do initial rehydration first. So for example, hydrate them in the first 6 to 8 hours and then start insulin, or whether we should just start insulin from the get-go. I think probably attempts to restore perfusion are going to be important. However, it's certainly not the case that your dehydration needs to be completely corrected before you start insulin. So in this JVEX article, they looked at a study of 60 dogs and cats that had either DKA or just DK, so diabetic ketosis. And a delay in insulin therapy of greater than 6 hours significantly delayed the resolution of ketonemia by actually an average of 19 hours. So the delay in resolution of ketonemia was much longer than the initial delay in giving insulin. However, there was no difference in complications seen. But I think it's a really important take-home message in that if you're presented with a really sick DKA and you've got a busy day, you start them on fluids, work out your hydration plan, and then when you've got a minute to breathe a little bit later, you can then work out your insulin. Don't try and calculate the insulin when you're under the pump and under pressure. You can certainly buy yourself some time in that regard. With insulin, I do prefer a CRI. I do think it is preferable to give insulin as a constant rate infusion. However, I think the most important thing is to just use a protocol that you're familiar with. Intramuscular insulin injections can absolutely be used if it's an uncomplicated case or if there's financial restrictions where putting them on a CRI is going to be more expensive, but you certainly do want to make sure that you've got some rehydration plans in place. So if we started looking at a feline DK management, because with cats there's a little bit more variability in protocols for cats, and I'm certainly not going through every insulin type and every protocol, but I just wanted to focus on the ones that you may have come across and the ones that I like. So this is the feline regular insulin CRI protocol. So it's 1.1 units per kilo of a regular insulin, and that goes into a 250 ml bag of 0.9% saline. You then want to drain out 50 mils of the solution because that allows for the insulin to get absorbed to the plastic tubing, and that just gets discarded. And then administer your insulin solution at a rate of 10 mils per cat per hour. And then there again, in a bunch of resources, there are these little tables that you can follow. So you've got your blood glucose in the left column, if you need to be starting glucose supplementation in the middle column, and then what to do with your fluid rate in the far right column. And you use that to influence your decision making. In cats, you can increase your CRI concentration to 2.2 units per kilo of regular insulin if you're just not seeing your blood glucose budge with a slightly lower concentration. The important thing when you use glargine in a DK protocol is it might be a bit counterintuitive because most of us are used to using it subcutaneously. So when glargine is given intramuscularly, it has a really short half-life, whereas when glargine is given subcutaneously, it has a really long half-life. So if there's been some confusion in the intermittent glargine injection protocols, that would be why. So in this study, they looked at intramuscular and subcutaneous glargine protocols for DKA. So it does look as a potentially promising alternative to insulin CRIs. And what they found is that if you treat cats with an intramuscular glargine protocol combined sometimes with or without subcutaneous glargine, that it can actually be a really effective management strategy. So what they recommended from this study is that you do glargine at 1 to 2 units per cat twice a day, starting immediately, and that's subcutaneously, and then a concurrent intramuscular glargine, so half to 1 unit per cat, and that starts several hours after fluid resuscitation. And you can do repeated doses of intramuscular glargine at that half to 1 unit per cat protocol, given up to every 4 hours to get a nice glycemic response. Most cats received only between 1 to 3 doses of intramuscular glargine before they then could just be managed with subcutaneous glargine alone. One of the limitations of this study, though, is that they didn't use a strict protocol for every cat, and there were electrolyte imbalances quite commonly in these cats, and some were quite severe. So it certainly looks promising, but certainly something where there's probably going to have to be a little bit more research. There's also been another study that looked at cats treated with a regular insulin CRI versus a subcutaneous glargine with a regular insulin IM protocol. And in the cats that had the subcutaneous glargine with intermittent regular insulin IM, they actually had a faster resolution of their hypoglycemia, faster resolution of ketonemia, faster resolution of their acid-base abnormalities, and a shorter hospitalization stay. But there's no advantage in survival between the two groups. And so this study has actually led to a few protocols coming out where you do a CRI of your regular insulin. So for example, at 1.1 units per kilo per day, and then you do 1 unit of glargine subcutaneously twice a day on top of that. And I have started using that only in a few cases, and it's worked quite well so far. Now, if we move to dogs, it is similar to the cat CRI insulin protocol, but it is a higher dose. So it's 2.2 units per kilo of regular insulin into that 250 ml bag of saline. Again, you need to drain out that 50 ml of solution to allow the insulin to absorb to the plastic tubing, and then you administer at a rate of 10 ml per dog per hour. And again, you use that table to titrate to effect. There are, again, canine protocols that involve intermittent regular insulin, and this is just one of them. So you're using a regular insulin at 0.2 units per kilo as an intramuscular injection, and then you follow that with a 0.1 unit per kilo regular insulin IM injection 1 hour later. Then your doses depend a little bit on how quickly your blood glucose is dropping. So it'll be between 0.05 units per kilo to 0.2 units depending on those guidelines. But once your blood glucose drops to about lower than 14 millimoles, regular insulin can just be given subcutaneously every 6 to 8 hours, and that's at normally about half to 1 unit per kilo. If we want to then look at how we're going to monitor our response to insulin and to IV fluids, you absolutely want to be checking blood glucose every few hours and adjust your insulin accordingly. I know that's obviously difficult with overnight care in general practice in some cases, so that is just something that you'll need to warn owners about. DKA patients can be really good candidates for central lines, although we don't do a huge number of them, and I think we probably have some really decent alternatives in that we have these Alpha Track and the Freestyle Libre now. So the Alpha Track glucometer is really good because it's calibrated for dogs and cats, and it uses a much smaller blood volume than the human glucometers. And this is really important because DKA patients, particularly little ones, can just get anemic from all of the venipuncture that we use to monitor them. And so having that smaller blood volume is really important. Alternatively, the Freestyle Libre has been really useful. So that measures interstitial glucose, so it's not going to contribute to any anemia through repeated blood sampling. And it's also really useful as often the sensor is still in place when these patients go home, so the owners can really easily be monitoring their glycemic control after discharge. And this group out of the University of Bologna did a study to assess whether the Freestyle Libre is actually accurate in dogs with DKA. So they wanted to make sure that various parameters wouldn't affect the accuracy of the device. So they looked at the severity of ketosis and acidosis, they looked at lactate concentration, body condition score, and also the time that the patient was wearing the sensor. And none of those parameters negatively impacted on the accuracy of the sensor. So there is this study that says that the Freestyle Libre is actually quite good, not just for stable diabetic dogs, but also for dogs with DKA. I'm not aware of an equivalent study in cats, but we certainly do use them in cats a lot with DKA. I think anemia is something that's often overlooked, particularly in cats with DKA. So the anemia can be iatrogenic, but it certainly can be hypophosphatemic. And in cats in particular, they get a Heinz body anemia. So cats are really prone to Heinz body anemias in critical illness, and it's possible that ketosis just enhances that risk. So certainly some owners should be prepped that some cats, or any patient, but certainly some cats actually do need a blood transfusion during their treatment for DKA. It's rare, but it certainly does happen. And then almost finished for treatment, I did want to just comment on acidosis in DKA, because I think, again, sometimes this can be a little bit controversial. So the metabolic acidosis of DKA really is going to resolve with your fluid therapy and your insulin alone. Sodium bicarbonate isn't sort of recommended anymore. If you do decide you have a case that's severe and warrants its use, you do just need to remember that bicarbonate is going to drive potassium into your cells, and that's potentially worsening your hypokalemia. So if you need to use it, then do, but just be conscious of some of the negative effects of bicarb. So it is going to affect your, it shifts the oxyhemoglobin curve to the left. So it's going to decrease oxygen release at the tissue level, and it can cause problems with paradoxical CNS acidosis and a few other things. So just have a really good think whether your patient does truly need bicarbonate or not. So with the prognosis, a lot of the studies that look at DKA says that DKA in itself is not a negative prognostic indicator. It's really the severity of the concurrent disease process and the commitment of the owner. So reported mortality rates range between 26 to 30%. So that's not insignificant, but most patients can actually do pretty well with various sort of intensity of treatment. Now, I actually specifically didn't want to go into hyperglycemic hyperosmolar syndrome tonight, and some of you may not sort of have heard of that disease. It's quite uncommon, but I thought it deserved just one slide to acknowledge that this disease exists, because if you're reading about DKA, you might actually read about this hyperglycemic hyperosmolar syndrome. So DKA and HHS are really similar in their pathogenesis, but ketone production is perhaps minimal or absent in hyperglycemic hyperosmolar syndrome. But because these patients really present with enough insulin to limit that lipolysis, but they don't have enough to counter the hypoglycemia. So patients with hyperglycemic hyperosmolar syndrome tend to be more dehydrated, but they're less acidemic, and they probably have lower counter-regulatory hormone concentrations than those with DKA. An important differentiation with these patients is that HHS patients develop a hypernatremic dehydration, and that's because their free water loss exceeds that of sodium. So your glucose urea really impairs the renal concentrating capacity, and that's going to exacerbate your water loss, and then you get this cascade of events. So just keep in mind that these patients are often profoundly dehydrated. So that's the end of the DKA, and that's the end of the pathophysiology. We're not really doing any more pathophys going into feline acromegaly. So feline acromegaly is also feline hypersomatotropism, and this is the only reference to anything slightly pathophys related. So it's just essentially a disease of abnormal growth hormone, so increased growth hormone, and that causes insulin resistance and diabetes because it's going to reduce your insulin receptors, and it also interferes with your post-insulin receptor processes. Now, with feline acromegaly, it's probably something we should have on our radar a little bit more than we do. So when they've done prevalence studies in UK diabetic cats, 25% of their diabetic cats had acromegaly, which is actually quite huge. You know, if you think of all the diabetic cats that you've diagnosed recently, would you think that 25% of them would have acromegaly? And that's important because in this study, only 24% of clinicians actually had a strong suspicion of acromegaly. So these cats can be really difficult to pick based on clinical exam alone. They often don't display the typical acromegaly signs, which we'll talk about. So the new recommendations coming out of the veterinary literature is that we actually should be screening for acromegaly in our recently diagnosed diabetic cats. So acromegaly is most commonly caused by neoplasia in the anterior pituitary. So essentially what happens is just that normal frequency and amplitude of that normal pulsatile growth hormone secretion all gets increased. Most of these lesions are going to be due to adenomas, but there have been some reports of carcinomas and non-neoplastic hyperplasia as well. Most of the clinical signs that you'll see are going to be diabetes associated, so your PU, PD, and polyphagia. It is really quite rare for acromegaly to present without concurrent diabetes. Having said that, they can have extreme polyphagia without diabetes. They can often present with an upper respiratory stridor or snoring, and that's due to the soft tissue swelling and narrowed nasopharynx. They'll have increased width of the head and broad facial features, and also prognatho inferior, so that lower jaw protrusion, like in this little ginger kitty in the picture. They can have clubbed paws, abdominomegaly and organomegaly, arthropathy. They might have a cardiac murmur or presenting congestive heart failure. Although I have spoken to a cardiologist, Rita, and she doesn't see a lot of acromegaly presenting that way, or cats where she thinks that there's a really abnormal heart size due to this disease, but they can also present with CNS signs. So that could be circling or blindness and seizures and so on. So really, I think for you, the time to consider acromegaly is when you have cats who gain weight, but they just have suboptimal glycemic control. So it doesn't fit with how a standard diabetic should present. And also if you get unexplained insulin resistance occurring. So if your insulin requirements are greater than 1.5 units per kilo per injection. And the main way that we diagnose that is with an IGF-1 level. So if it's greater than 1,000, then that's going to be really strongly suggestive of having feline acromegaly. But ideally don't test right at the beginning of insulin treatment in newly diagnosed diabetic cats, as you can get a false negative in about 9% of untreated cats. They need to have had some insulin supplementation for a while to increase the chances of you getting a legitimately positive result or legitimately negative. The other test that we can do is certainly advanced imaging. So looking for pituitary masses, looking for some of the structural abnormalities like the prognatho inferior. These cats often have temporomandibular junction malformations, and we can identify that they have this increased thickness of their skin and subcutaneous tissue and their calvarium bone as well. And in this study, they looked at 3D rendered CT images of acromegalic cats. So this cat here is a normal control cat, and then B, C, and D are all cats with acromegaly. So there's this widening of the head, there's uneven thickening of the soft tissues, and particularly in D, you can notice the prognathism of that jaw. So treatment, absolutely hypophysectomy is the gold standard, and it's going to be ideally a definitive treatment. And about 85% of cats that enter diabetic remission, 85% of cats will enter diabetic remission within about 2 months. And of those who don't enter diabetic remission, they're actually just much easier diabetics to manage. So often much better than what they were preoperatively. The peri and postoperative mortality rate is about 10%. Certainly these cats need long-term management, so they will need low-dose cortisone and thyroxine, and that will be lifelong. But the desmopressin supplementation that they need is often only in the short term. There is pasireotide, which is a somatostatin analog, and that's one of your medical treatment options. So there are 2 protocols in the literature. One is a short-acting injection twice a day, and the other one is a longer-acting injection once a month. And in a study of the once-a-month injection cats, 25% of those cats did enter diabetic remission. The major limitations is going to be that most cats will have diarrhea, and for some cats, that diarrhea is a big enough impact to stop treatment. the vials are really expensive. So I just have looked this up, and the cost to us for the vial is $4,000, and you can get often only one treatment out of the vial, maybe a couple if you're lucky. So that's $4,000 a month if it's at cost. But also there's just not a huge amount of studies. So there is definitely lack of information regarding the ideal dosing frequency. Radiotherapy is something that can be considered. However, the response is quite unpredictable, and the main time that you'll use that is going to be just to decrease tumour size. So if you have a cat that has a really large pituitary mass and you're worried about the risk of surgery, because we know that risk increases with the bigger tumours, then radiation might be worth considering. Alternatively, you just need to focus on managing the diabetes. So often with really high insulin doses. And the tricky thing with these cats is that it's not just like this constant high level of growth hormone. So the growth hormone secretion is still going to be pulsatile at times. So you can get periods where you get an iatrogenic hypoglycemia because you've actually gone down to a sort of low growth hormone concentration period, and then you're going to have an increase in insulin sensitivity. So it's important to warn owners that they may be more likely to see episodes of hypoglycemia. Then absolutely your other supportive care measures. So analgesia for arthropathies, chronic kidney disease management, and then treatment for cardiomyopathies or heart failure if that occurs. And that's acromegaly very quickly, and reference for those that are interested. That's it.
Nice one, Liz. Thank you very much for that.
Any questions?
Just got a question from Helen. Would you put your K-Floss into the saline bag with the insulin CRI in DKA, or have 3 separate fluid bags?
I like separate fluid bags, or often I'll just put in like a little syringe driver, because you're going to be changing everything independently. So I would definitely prefer to have it all separately. Yep, great.
Helen's on silent because she's got a bit of background noise at her place.
Yeah, no, that's okay.
It was an awesome talk going through all of that stuff, and just sort of for reference, like across sort of specialists, everybody does things differently when it comes to DKA.
Yes.
And literature to support everybody's different theory. And I think the most important thing that Liz pointed out was like do things that you're used to, comfortable with, and that your team are capable of. Like if you've got a really surgical heavy practice, you don't want to be studying insulin CRI with a team that's going into surgery and not going to be available for 4 hours to check on your patient or something along those lines. So just make sure that whatever you're doing suits not just the disease, but also the patient and your environment, and obviously finances and every other factor.
I think that's a really good point. And I think probably where I find I give myself an ulcer with DKA management is when you pick up someone else's DKA case and they run their CRI differently, and you're just not used to the maths, and you actually have to sit down. Whereas if you stick to a protocol that you know, you can just walk past the cage and go, okay, this is what's happening. I know how I want to adjust my fluid rate with my insulin, and you can just do it without sort of thinking. Whereas when it's a different protocol and you're worried about, because the consequences of getting it wrong are not insignificant. It's like, okay, I've got to sit down with a calculator and work this all out. So picking a protocol that you're comfortable with, I think, is the most important thing.
For sure. And do the maths yourself, like regardless of whether you're picking up somebody else's case or your own. Yeah, you've got to sit down with a calculator and be comfortable with the rates, because otherwise it's a nightmare.
Yeah.
Thanks so much, Liz. Thanks everybody for coming.
No worries. Thanks, everyone.
And we will see you Wednesday morning for Mariano radiology rounds. And on Friday, I did rounds on DKA last time. So this Friday, I'll actually be doing some anemia workups and blood tests and just running through those, just a case-based discussion. So hopefully we'll see you all then. Cheers, guys.